Welcome to the podcast of the European Society of Anesthesiology and Intensive Care, ESAIC. I'm your host, Dr. Saxena from the University of Mons in Belgium. And in this episode, we will talk about the future of hemodynamic management together with the famous Professor Mike Grocott from the University of Southampton. And before we get right into it, I'm happy to disclose that this episode is kindly sponsored by Sintetica, BD, and Medtronic. Professor Mike Grocott, welcome, and thank you for joining me in this discussion. It's amazing to have you here. So today we're talking about the future of hemodynamic management, quite exciting. And I guess before we look at the future, let's stay in the present. Why is it so necessary to keep on talking about hemodynamic monitoring? We're actually quite far ahead, or not?
So, first of all, thank you very much for having me on the podcast. Really appreciate it, and your kind words. And I wonder if I'm the right person to be asking the question, because I'm a bit of a hemodynamic monitoring geek. So, you might get maybe a little bit of a biased view, but it's a topic that has interested me since I started as a trainee anaesthetist in the mid 1990s, and over the years, I've been involved in clinical trials, and I've been involved in some more basic science research about it. And it is fundamental to the practice of anesthesia. We put people asleep for surgery. We make sure they're comfortable. We wake them up at the end. That's clearly key. But as a consequence of that, we typically disturb their physiology, and not uncommonly, that results in significant hemodynamic disturbance, and particularly in patients who are older or frailer, a bit more comorbid with different conditions. It results in really significant hemodynamic disturbance, and we know that it's completely embedded in our practice because the fluids are there all the time. They're arguably the most prescribed drug in hospital. It's either fluids or oxygen. And frequently, certainly with major surgery, but even with older patients in minor surgery, we see administration of different types of drugs that affect hemodynamics. So pressors in particular, and also sometimes inotropes.
So what have been you said you've been working on this since the 90s, so that's really interesting. What have been the biggest challenges in your learning curve, in your career, when it comes to hemodynamic monitoring? And what have been the biggest successes, I guess?
So I'm feeling really old now. When hearing that played back to me, I'm thinking people are going to listen to this and think, this is an old guy. I guess the thing that's intriguing for me is I think we have a pretty good, although not perfect, handle on the physiology. We've understood a lot about cardiovascular physiology for more than 100 years. And yet when we try and translate that into the clinical space using the tools that the modern day tools that we have for evaluating novel interventions, so particularly the randomized controlled trial, we really struggle. And I think, and by struggle, I mean, we end up with a big, complicated literature with confusing findings. If you come to it fresh, it's a morass. It's a nightmare. There's a lot of different studies. Many of them are very small, so it's difficult to know what to take from those. There are a few larger, what one would hope would be more definitive studies, and typically they show no difference. Now, I'm an intensivist in my clinical day job these days, so I'm used to studies that show no difference. It's a bit of a habit for intensivists. But you then have to ask yourself, is it because this is not relevant or it's not important, or is it because of the nature of the technology we're using to evaluate the technology? Can you really use a randomized controlled trial to evaluate a complex intervention, which is a hemodynamic intervention, the use of hemodynamic monitoring and some drugs, so fluids and other drugs, to correct different types of disturbance? So it might be hypotension, but it might be low flow, or it might be a combination of the two, in what is almost always in a big study, a fairly broad, mixed, heterogeneous, as we say, group of patients. And I worry that we're some of the problem is in the way we're doing the trials, and this is a particular bias of mine. I think we're still, if you look at other clinical contexts, our trials are not that big. The cardiologists don't think twice about randomizing tens of thousands of patients. We've never done that. We think it's really cool when we randomize 2 or 3 or 4,000 patients, but actually I think so some of it may be numbers, but I think a lot of it is the challenge of using a randomized control trial, which gives you a binary answer to an apparently simple question when you've got a very complex intervention in a mixed group of patients.
So do you think this is because the title of this podcast is The Future. So moving forward, let's say in the next 5 years, do you think that first we need to figure out how to do these randomized control trials in the right way? Or would you just say that we do not need these at all? We need a whole other structure to look at it. And how would you see that before we can implement everything that you want to implement? What do we need to do to get there?
So I guess that depends on whether we step forward or we leap forward. Because I think the near future, we're probably going to carry on doing basically what we've been doing so far and achieving a similar result.
Yeah.
One of the things I find most intriguing is the possibility of closed loop systems.
Yeah. Okay.
Which I think we know are feasible. So people have been doing great research on this since at least 10 years ago. People like Maxine Cannison's done some great work, and others. And so we know they can work, and we know they're frankly much more reliable than people. And whilst on an individual basis that sometimes feels a bit uncomfortable, I think culturally we're going to get much more used to that as an idea as we get used to other technologies where that is common. So self-driving cars being the obvious analogy, as their prevalence increases, and I don't know if you've ever been in a Tesla. I've never owned a Tesla, but I've occasionally been lucky enough to get in one, typically as a cab, and you can, you take the hands off the steering wheel, it drives itself. And the newer technologies are getting smarter and smarter, and I think it will be, we are getting used to it already in terms of anesthetic machines, the administration of volatile anesthesia, for example.
Do you think, because there's a lot of talk now, looking at the future about AI, right? And artificial intelligence in healthcare as well, different fields, a lot of studies on this topic. Do you think, with this being talked about, I guess, outside of the medical hemisphere, do you think it's easier for us to incorporate this now in our daily practice? My first question, and also what you worked on was, you spoke about closed loops. Do you think with AI being slowly incorporated into the healthcare, into the anesthesiologist's daily life, do you think that closed loops will get a bit more of attraction again compared to before? Or do you think people are still resistant to this? And what scares them? Why are people scared of this, actually?
Okay, so to answer the two questions you posed there, yes and yes. Frankly, I think it's inevitable. It's a when, not whether question. The companies are working on these types of technologies. The researchers, and I don't directly do closed loop research myself. I'm a very enthusiastic observer. But researchers, multiple researchers have shown that it's feasible. It's so much more reliable than humans, and like I said, I think it's a when, not whether it's going to happen. At the moment, I think there's a whole spectrum of opinions. Some people find it uncomfortable that aspect of care might be taken over, but it is fascinating how readily they've accepted automated closed loop systems in other aspects of care, and I think it's inevitable.
Yes.
And the reason that's interesting is because then, if you've got a much more reliable system, it's going to be easier to separate the signal from the noise and work out whether the strategies that we're adopting are beneficial or harmful or make no difference. because at the moment the noise from the practitioners is extraordinary. And there have been some fascinating studies looking, just simple large-scale population studies looking at administration of fluids, which suggests that the biggest determinant is not blood loss or length of procedure or even type of procedure. It's which anaesthesiologist, which anaesthetist walks through the door. And then the second biggest determinant is which surgeon walks through the door. And that can't be right.
Human factors, which is now actually taken away by that human factor, but also the human error. And especially we as anesthesiologists and intensivists also work at odd hours. So we do tend to, sometimes be tired. So in those moments, you have something that's very reliable, straightforward, the closed loop system. AI as well. Do you also think that this is a generational issue? We have now Gen Z, coming up. Gen Z will be the next generation of doctors in 10 years. And this is a generation that's really grown up with internet, technology, AI now. Do you think they will be less reluctant to adopt this compared to the previous generation?
So I guess I'm not the right person to ask for talking about Gen Z, but I would hope so, and I would expect so, given their life experiences along the way.
What are the pitfalls, though? What do you think? Where can this go wrong for the people who are reluctant to introduce this? Why do you think they're so reluctant?
Well, so I'm not actually sure I'm not sure we've tested that reluctance. So at the moment, it's tested at the level of a conversation like you and I are having, and people might have, they might have at work or they might have in the social environment after work, but we haven't had the opportunity for large scale adoption of systems that you can implement in clinical care, as far as I'm aware, in any healthcare system around the world. Yeah. So I think at some point, I would guess quite soon that question will be tested. Mm-hmm. And it is fascinating. Different environments may have different approaches to that. And one of the things that intrigues me is that in the US market, where the financial drivers are so strong, and there are some big, so there are now big anesthesia provider companies who employ large numbers of anesthesia providers, both physician and non-physician, and who are more, in some cases, more prescriptive about the style and type of practice. If I was running one of those, I think I'd be looking very carefully at something that did two things. One, because the reliability thing there's two aspects to it. One is the variation between individuals and their style of care. So some people may be very generous in their fluids. Some people may have, really gone overgone that enhanced recovery approach and be very restrictive in their fluids. And so that's one element. And then there's for that individual over time, how reliable are they at delivering what they think they're delivering, and sticking to it when the surgeon distracts them or somebody walks in from the anesthetic room or, events overtake them. So both the reliability of the individual at doing whatever their favored strategy is, but also convergence of those strategies. And I think at that point, we're likely to start to develop a much better idea as to what the right approach is. What's interesting to me, having been involved in a number of the goal-directed fluid therapy studies, right now the pendulum seems to be swinging more back towards blood pressure control. Mm-hmm. But I'm confident, a new generation will come along and go, they really did those studies wrong. We need to do them again. And I don't expect those questions, those boxes to be reopened in the next year or two, or maybe even 5. But I think, people, as patients change, technologies change, approaches like we've just been talking about change, I think those areas will be revisited. And then, as I head off into my retirement, we'll discover what the answer was. And we'll go, told you.
Sorry. Okay. And also, how do you see, what is an ideal future for you when it comes to hemodynamic monitoring? Let's say in 5 years, let's say in 10 years, and then let's go crazy 25 years. What do you think? We're now talking about closed loops. As you said, 10 years ago, this has been studied since 10 years. It's not worldwide adopted. AI is there now. How do you think this can evolve? And what do you also, so that would be the first question. Let's go 5 years, 10 years, 25 years.
Okay, I'm going to struggle with I can't tell you whether it'll be 5 or 10 or 25, I'd be really surprised if we don't end up in a situation where closed loops are available and many people use them for most of the time, because it's just easier, and we'll, as a new generation comes through who start to learn on those types of systems, they'll be asking themselves, why on earth would you do it any other way? Why would you have a pseudo-random method of administering something where you can just program it in? And even better, you can program it in to match a flow or pressure variable. So I think that'll come. I do think we need to work back from, because we're focusing on the technology and by inference the physiology. Actually, we've got to work back from what's going to be best for the patients.
A more personalized approach, would you say that?
I'm sorry, say that again.
Go to more a personalized approach?
Well, we need to understand what the effect on outcomes are, and I'm sure inevitably it's going to be a personalized and individualized type approach, because we're all different. We know that. To be fair, many of you can think of a flow directed, so goal directed fluid therapy. You can think of that as an individualized approach, although what we're doing is we're trying to hit a target for that individual, but whether that's the right target for that individual, we don't know. So I think there's still quite a lot of work there. There are clearly there's some really interesting work looking at different so-called endotypes, so different types of hypotension or shock, and what underpins them, what the underlying cardiovascular, and separating those two out, physiology or pathophysiology is. So I would imagine that the appropriate hemodynamic management for, say, a young, fit athlete with a strong heart and a compliant vasculature who has a traumatic fracture is highly likely to be very different from the emergency laparotomy in an older patient who's got a much less strong heart, lower ejection fraction, and a vasculature that's suffering a bit with lack of vascular compliance, hypertension's creeping in. That it's hard to believe that they would merit, that it would be right to target the same values in them, or possibly even the same strategy. So I think we understand, as with many things, the overarching physiology, but we're going to have to explore the specific physiology and pathophysiology of different types of patients.
Okay, thank you for this. Another question is then, we're talking about hemodynamic monitoring, etc. Oftentimes, so I spoke about reluctance to adopting closed loops. When it comes really to monitorings, we sometimes have that in the OR and still people are not using it. How can you convince a colleague to use something? Even sometimes you have something right next to you and people are just not using it or adopting it because they're not, I don't know the reason. What would you say?
I'm not sure we're very convincible. If you look at, this, I'm not the first person to say this, but the pace of innovation is often driven almost as much by the pace of turnover of individuals in the workplace as by individuals adopting innovation. Now, that's not always the case, and there are some striking examples. The introduction of capnography, for example, where there was a widespread, rapid change in practice across a lot of, certainly, the rich world at that time. I think the monitors have been around long enough that people tend to have reasonably fixed views, and they tend to learn those views from the people that teach them. And it would take very compelling trial data to alter those. So the change is modest and incremental over time. That and it isn't all about closed loops, but I think if closed loop technology becomes widely available, that may change. Because it strikes me as a deeply disruptive technology, and I'm less sure that we're reluctant. And I know we've sort of come back to reluctance, but I honestly don't think we've tested the reluctance. If it was readily available and you could just say, there you go, you can keep the blood pressure where you want it for the next hour and a half. And we'll keep an eye on we'll look out for the lactate and we'll make sure perfusion's okay, and we'll give you a measure of flow. I think people may enjoy that world, and it will enable them, because at the moment we're investing a lot of time in doing something that a device potentially can do for us. They can then spend more time, making sure that they're having a look over the drapes, seeing what the surgeon or the robot's doing. Thinking more broadly about this patient's physiology, how they're going to manage them into the post-op phase, for example. So I think it will, as all sorts of technology do, I think it will the job will evolve, and we'll no longer think, I suspect, of that as one of the fundamental things that we do. It's largely controlled by devices, and then we make very clever decisions to tell the device to do something a bit different.
So I really like this because when I talk about some people about the introduction of AI, people are always obviously scared to lose their jobs and being replaced by a machine compared to a human. But I like what you're saying is that our jobs will evolve and we will go into the perioperative sphere, which sometimes at the moment is still neglected as anesthesiologists. We tend to focus on the intraoperative period, which is the majority of our work, but the pre and post-operative side is obviously very important too. And we need to obviously venture to those sides as well. So by hopefully introducing these technologies, we can do that. You also mentioned that what's really important is the people that we learn from. So education is very important here. What would you recommend to the younger anesthesiologists, the 5, I would say in the last 5 years, the articles that came up that are really important to look at? And what would you recommend in the next 5 years as a young anesthesiologist to do as well?
Really interesting question. I read too many papers, so I'm a bit... So I think, and I think it might be outside the 5 years, I think the paper that I alluded to about individual variation in practice is one of the most important papers I've read, and there are others. There's a group of papers that have come up with similar observations, because it gives us a window. When we practice as anaesthetists and often as intensivists, we go into the room on our own, and we do our thing, and we think we're doing this. We presume, I guess, that we're doing broadly the same as other people, but it gives us a window on the extraordinary variation in practice that there is between individuals, and that finding seems to be reliable across different systems. And if you look at, although it's not reported in that way in randomized controlled trials, if you look at the variation in, say, volumes of fluid given or that kind of thing, it's very hard to believe that that's all explained by the patient variables. Some people seem very parsimonious with fluid, some people seem very generous with fluid, for example. And I think having that window looking from the outside in on our practice is really useful, and maybe begs some reflection about the practice. I think, so that the big goal-directed randomized controlled trials, I think they're important to know about. But at the moment, although we've had Optimize and Optimize 2, which have come out as negative trials. I did a Cochrane systematic review probably 15 years ago now, which suggested there was a beneficial effect. There's all sorts of problems with that because of small studies, heterogeneity of different types of populations. But I suspect that there is an effect. I'm fascinated to see how the Floella study turns out. That's a UK-based study, but a big one, over 3,000 patients, it doesn't include inotropes. It's fluids only in emergency laparotomy surgery. So I think that'll be very interesting. I think Relief, so Paul Miles' randomized controlled trial conducted in Australia, looking at a more generous and a more restrictive approach to fluid management, which, although it didn't show a difference in the primary outcome variable, did suggest that if we get over restrictive, we can the kidneys are harmed. So the acute kidney injury signal in that, I think, is significant, and a little bit of a warning bell in the context of enhanced recovery, where what was originally framed as please avoid fluid overload has been translated over a couple of decades into fluid restriction. And if you speak to Henrik Kellett or the originators of enhanced recovery, that was not their intent. What they wanted to avoid was the drowning of patients with very luxurious, overgenerous amounts of fluid. They were not suggesting that we give no fluid, and that unfortunately is how it's been interpreted. So I think relief is a really useful check on that. And then I think some of the epidemiological studies, Dan Sessler's, for example, on blood pressure are fascinating, because we've tended to assume that low blood pressure outside of shock states is probably okay. And I think we're starting to get the message that there's a myocardial harm signal, there's a renal harm signal. That there's not a huge amount of data in the interventional space yet, but I suspect that'll come, but we'll see. But I think that if I was going to pick, I don't know if I got to the 5, but that as a sort of things that affect my thinking from the last 5 or 10 years, those are probably the most striking.
Thank you. This was really interesting. So I think we got some follow-up things to look out for in the future. I would like to thank the audience for listening, and a warm thank you to you, Professor Grocott, for taking part into this discussion. The ESAIC releases monthly podcasts on the ESAIC website and various streaming platforms. We hope you will join us for the next one. In the meantime, check out the ESAIC Academy to discover more enlightening talks.